I hope you're enjoying your lunch. We welcome you to this symposium. It's on blocking type 2 inflammation and chronic rhinosinusitis with nasal polyps with targeted biologic therapy. So we're going to just jump right in. My name is Amber Luong. I'm one of the rhinologists at McGovern Medical School at Houston, just down the road, so drove in this morning. So hopefully you're enjoying the weather, a little warm, but not too warm. We have Dr. Chris Codispoti. Do you want to introduce yourself, give a little background?
Sure. Can you hear me?
No, not yet. Sorry, maybe I should have.
I think it's okay. Chris Codispoti. I'm also right up the road as well. I'm an allergist immunologist, so work at UT Health.
All right, and Carly, you guys know Carly.
Hi, my name's Carly. I am a PA. I'm a member of SBAO. I'm happy to be here with you guys today. My background, I've been a PA for 3 years, practicing that entire time in rhinology and skull-base surgery at the University of Pennsylvania. Thank you for having me.
All right, so you guys are going to get a little bit of perspective from, different from an allergist, a rhinologist, and in your shoes as a PA helping to take care of these patients. We want to thank you to PeerView for providing this session and for Regeneron and Sanofi for providing the educational grant for this symposium. So as you heard, there's a lot of opportunities to get a little gift card, a little bit of fun, gadgets, and games. So make sure you complete your pre-event survey, looking for the additional polling. And as you heard earlier before we started the symposium, the more things that you do, the higher chance that you will be able to win. So virtual learners, go ahead and go on your screen. So with that, I'm going to just jump right in. You can see all the different ways that you can win by doing all these different activities. And then they want to make you aware of the website so that you want to have some additional slides or access to these slides or some practice aids. They can be found there. Okay, so for today, what we would like to do is go over the signs and symptoms of chronic rhinosinusitis with nasal polyps, which is often associated with a type 2 inflammatory disease process. We're going to kind of go over some of the patients that may be candidates for a biologic therapy, talk about some of the presentations and their characteristics, and really think about personalized and multidisciplinary and then effective planning on, the response and how do you follow someone that you put on a biologic? How are you going to assess whether or not they're responding or not responding and whether it's time to switch or this is a good candidate for a biologic. So with that, I wanted to just jump right into the characteristics. I know that I understand that some people have been here and doing the job for a long time and so know these symptoms and findings very well, and some of you have just recently started seeing some of these patients. So chronic rhinosinusitis with nasal polyps is defined by both symptoms and objective findings. So these symptoms usually have to be going on for at least 3 months, so we're outside of the window of acute or subacute, but now chronic is 3 months of these symptoms. Some of the more common symptoms, and the criteria is that they have 2 or more, is going to be discolored drainage or abnormal drainage, nasal obstruction, not being able to breathe through their nose, facial pain and pressure is a very common symptom, and then challenges to their smell, so either lack of smell altogether or a decreased sense of smell. And then some objective finding, whether that's on nasal endoscopy, showing here the polyps, as you can see, or the CT scan showing a pacification of the sinuses. And so there's 4 pairs of sinuses, and so you can see on that x-ray that they're near complete opacification there. So some of you may know that this is not an uncommon symptom. About 12% of patients are diagnosed with chronic rhinosinusitis. And in nasal polyps, they do typically present a little bit older, although there are some subsets of CRS with nasal polyps that can present younger. But usually you're looking at the 40 to 60-year-old. And then there's a slight difference in terms of gender presentation, with men presenting more than women. They can obviously affect the quality of life. That's why they come to you, right? So for those of you who don't know chronic rhinosinusitis very well, think back of the time when you had a sinus infection and imagine having these symptoms for 3 months, 6 months, a year, or several years. So we went over the loss of sense of smell and taste, the drainage, not being able to breathe. A lot of times, cough. We will talk about how asthma is oftenly associated with chronic rhinosinusitis with nasal polyps, so it can exacerbate their asthma symptoms. And a lot of my patients also talk about their ears bothering them because of the eustachian tube in the back of the nasal pharynx. And then there's a lot of sleep and emotional symptoms that can be associated with this. It's interesting when they look at the patient-reported outcomes. This is an HRQOL, quality of life. You can see that for those that are, I don't have the mouse, here we go. You can see here's chronic rhinosinusitis with nasal polyps. These are different patient-reported outcomes, kind of a global symptoms, and the lower the number, the worse they are feeling. You can see that chronic rhinosinusitis is on the same scale as type 2 diabetes and asthma for these various different components of this SF36. So their quality of life is almost as bad as someone with diabetes. If you can imagine that. This was a study that I think Chris will go back to, but they looked at 29 patients with chronic rhinosinusitis and asked, how is it affecting their sleep? And you can see here that, 20% was having problems with staying awake during the day, a higher number with insomnia, and then altered sleep quality, which I hear quite a bit. And then what are the typical treatment options you'll talk about? So, usually we talk about saline irrigations, nasal steroid sprays, either through their irrigation or topically through a spray. We've got exhalation delivery devices, which shown to have a little bit better penetration into the sinuses. If there's an active sign of an infection, antibiotics can play a role, but remember, this is an inflammatory disease process, not an infectious, so really antibiotics should only be used if you see active signs of an infection going on. And then systemic steroids. Obviously, before we really understood the side effects associated with chronic giving oral steroids, we were giving them out like candy, but now we're starting to appreciate some of the long-term side effects associated with that. But systemic steroids can be a very effective way of managing inflammation. And leukotriene modifiers, montelukast, really more for your asthmatic patients, less so for chronic rhinosinusitis with nasal polyps. And if those fail, those patients then are looking at a surgical option. And the goals of surgery there is, unfortunately, not to cure the patient of inflammation, but rather to provide access of the sinus lining to those topical therapies, to remove the polyps, to help with some of those symptoms. So by removing the polyps, the patients will breathe breathe better, much quicker. And then post-op surgery, because of course the surgery doesn't cure them of this inflammation, it's really important to remind patients that compliance with an anti-inflammatory, such as a topical steroid and saline irrigations, are very important. But unfortunately, as we've known, and over the years it's gotten better, but there is a cohort of patients that don't respond to surgery and postoperative care. And in the past, we were doing multiple surgeries. In fact, there's a special cohort of CRS with nasal polyps called aspirin exacerbated respiratory disease. These patients sometimes would show up with like 6 or 7 surgeries. So there's definitely a group of patients that don't respond don't do well with just surgery and post-op care, and may require something else, either that's additional surgeries or now we have available biologics, which we'll talk about. So, just to highlight, once upon a time, at least 40% of patients would not do well after surgery. So at least 60% did well. And then a really good meta-analysis that was done that included over 30,000 patients of CRS with nasal polyps found that the revision rates of surgery is about 18.9%. However, there are cohorts of patients such as 24.9 or 28.7, special groups of AERD patients or allergic fungal rhinosinusitis patients. These are special CRS with nasal polyp patients that had even higher surgical revision rates. So definitely a group that may need something better than, oops, can I go back? Oops. Oh my goodness, it doesn't want this one. And so we're going to talk a little bit about, why it's so important to look at CRS with nasal polyps, and who are those patients that don't do well with surgery, don't do well with postoperative care. And we'll talk a little bit about if you don't identify these patients well, then they are looking at, additional surgeries, additional treatments that may be not necessary. And now that we have biologics on the treatment regimen, this is a really good cohort of patients that can be caught early and treated now, rather than having revision surgeries over and over or suffering without good control. So with that, I'm going to turn it over to my colleagues. Chris, I think I'll hand it to you. Oh, you've got one. Perfect.
Thank you very much, Amber. Yes, so what is the future of chronic rhinosinusitis with nasal polyp care? A personalized approach with targeted therapeutics. So we're going to talk now about what is type 2 inflammation-driven chronic rhinosinusitis with nasal polyps. So this is a nice diagram. It kind of tells you what's going on at the mucosal level and why this matters. And, type 2 inflammation explains the persistent nasal congestion and the polyp recurrence. It also drives the eosinophils, which cause, when we say there's a lot of them, we say eosinophilia, and IgE production. And you'll see that here, if I get the mouse, there you go. So there's the eosinophils, and then is associated, and there's the IgE production from the B cell that's then binding to the mast cell, the IgE receptor on the mast cell. And that's all associated with asthma and other atopic diseases. And type 2 inflammation identifies patients who may benefit from biological therapy. Now here in the red circles are some of the agents that we have that target this pathway. We have an IgE, there's an anti-IgE, which we'll talk about, the anti-IL-4s, IL-5s, IL-13s, and the TSLP. So what are the clinical cues of type 2 CRS with nasal polyps? So you'll see that there's bilateral nasal polyps. This is suggesting there's something underneath that's driving it, not just something localized. Chronic nasal congestion, reduced sense of smell, the elevated eosinophil counts, the eosinophilia, comorbid asthma, which is one of the biggest comorbid atopic disorders, frequent steroid bursts, because you have to use a strong anti-inflammatory, and the rapid recurrence after surgery. Oh, my bad. So, question, and you can answer this all on your device. Which of the following clinical features most strongly suggest type 2-driven CRS with nasal polyps? So 1, unilateral nasal polyps. 2, comorbid asthma. 3, acute facial pain and purulence. 4, history of recurrent sinus infections. Or 5, I'm not sure. So give you a moment here. Okay, so a lot of you are kind of thinking comorbid asthma. It seems to be the most common answer, but let's go over this.
And look at that.
Yeah. Only
in a very short amount of time, they've already realized that asthma is a comorbid. So
Yeah.
I'm glad to see that we're learning very quickly.
So what is the prevalence of the type 2 inflammatory comorbidities with a focus really, especially on asthma, because there is a linkage between the upper respiratory tract and the lower respiratory tract. So up to 65% of patients with chronic rhinosinusitis with nasal polyps have comorbid asthma in some studies. So in general, the prevalence of asthma in the US population is 8.5%. But when you look at it, CRS with nasal polyps tends to be associated with more of adult onset asthma rather than the childhood allergic asthma that you would typically see. Now, chronic rhinosinusitis with nasal polyps plus asthma, that endotype is associated with more severe type 2 inflammation compared to just chronic rhinosinusitis with nasal polyps alone. And here's where the difference between that 8.5, up to 26% of patients with chronic rhinosinusitis with nasal polyps have comorbid non-steroidal anti-inflammatory drug exacerbated respiratory disease. And that's the more generic term for that we're going just from the aspirin exacerbated respiratory disease to now just non-steroidals, because it can happen to any non-steroidal anti-inflammatory.
I'm going to walk you guys through a patient case of mine. I met this patient a couple of years ago. He walked into our clinic, 73 years old, history of chronic sinusitis with nasal polyps, also had a history of asthma. When he arrived to our clinic, he told us he'd had a previous sinus surgery to remove polyps somewhere around 2015, and he did pretty well after that surgery, but then started to have a recurrence of his symptoms, and the providers taking care of him chose to initiate him on dupilumab. He did really, really well, improvement in his symptoms, but unfortunately came off of that medication due to insurance and cost. After he came off of that medication, his symptoms came back pretty quickly. He was describing to us a lot of nasal congestion, facial pain and pressure, and then most bothersome to him actually was his sense of smell started to go away. So he came into the rhinology clinic and said, I think my polyps are back. So for the panel, what kinds of type 2 inflammation are we seeing in our patient Jack so far? What about his story is leading you to think that this is type 2 inflammation?
Chris?
Well, I mean, I think his asthma is a big predictor.
Yeah, and I think another thing that we talked about, I highlighted some of the symptoms, but this loss of sense of smell is more commonly found, so in chronic rhinosinusitis with polyps. So you have both patients with polyps and without polyps, and they have a different inflammatory profile typically, but the ones with polyps often come and present with, I can tell that the polyps are coming back when I can't smell as well. So that's a really good, a nice kind of sign or hint that we're looking at someone with polyps in a type 2 disease.
And what type of testing would you recommend for this patient? He comes in the office and tells you all that I've described. What are your next steps to work this up?
Yeah, I mean, from a clinical history, where he's worsening, but also from just like a biomarker perspective, I'd like to know if he has elevation of the eosinophils and also the IgE. Yeah.
And I would say that these patients need to be scoped and seen with some sort of rigid or even flexible scope, just to make sure that in fact the polyps are coming back. A CT scan can sometimes be helpful, but it doesn't necessarily confirm a polyp versus a non-polyp that's happening. So
yeah. We always CT scan these patients in the clinic, and that can also give you some information onto how complete their sinus surgery that they came to you before was, and whether or not there are any other surgical areas to address. A lot of times, particularly the frontal sinuses, can go sort of under-addressed in an older type of surgery. And so how are we going to be talking with Jack about the severity of his chronic sinusitis with nasal polyps?
So at least in the rhinology world, we use a lot of patient-reported outcome measures because, as I mentioned at the beginning, this is a quality of life and symptom, is important in this disease process. So you want to know where they are in terms of the severity of their symptoms and what is the symptom that most bothers them, because that'll help dictate also what type of treatment options you may offer or suggest more strongly over another option.
Okay, so, kind of going along with that, what assessment tools do we have, what do they measure, and how to interpret? So there's a couple different ways you want to proceed, get an understanding of what's going on with the patient. All in all, though, as Amber mentioned, the patient perspective, the patient-reported outcomes. So we have the nasal polyp score, and it's endoscopic grading of polyp size in each nostril. The scoring range is 0 to 8, where on each side it's 0 to 4. And the clinically important difference is 1 to 2 points. So if you see a drop of that, you say, wow, we've made a significant improvement. That could be validated. Now, another one is the SNOT-22, the Sinonasal Outcome Test. Now, this is, we were talking about, a patient-reported quality of life questionnaire across nasal, sleep, and emotional domains. It scores from 0 to 110, with the higher score equal to a worse score. So, but if you see a change in 8 to 10 points, that would be clinically important. You can always use the visual analog scale. It's a patient-rated symptom severity scale about congestion, smell, facial pain. It's that 0 to 10 scale. But if it decreases by more than 3 points, then you're like, wait, we made improvement in our treatment. And then there's olfactory testing, and there's the UPSIT and sniffing sticks. These are objective smell function scores. The scoring range varies by test, but an increase in the score means an increase of the smell. So another question on your device: when monitoring response to treatment in patients with chronic rhinosinusitis with nasal polyps, which tool will you now most commonly use to assess changes in symptoms and quality of life? We use the nasal polyp score, patient-reported outcomes such as the SNOT-22, the VAS, or olfactory testing, an informal symptom discussion without standardized tools, or number 4, I do not really routinely assess treatment response. So I'll give you a moment here. Pretty good response there, I'd say. I think we've kind of discussed the importance of getting the patient perspective, and that's where we're going in healthcare in general. So determining when to initiate treatment with a biologic. So selection of a biological drug and monitoring its effectiveness. You want to actually confirm the diagnosis that you have this correct of an uncontrolled severe chronic rhinosinusitis with nasal polyps. You want to check for any comorbidities such as asthma, that NSAID, exacerbated respiratory disease, and other consequences. Check that the type 2 inflammation is highly likely. Inform patient on treatment options, perspectives, risks, benefits, have that shared decision making. Take decision on surgery or biological with an informed patient, and then select a biological drug with no limitation applicable, and then with CRS with asthma, a collaboration with an asthma specialist is essential for indication and selection of biologics. So maybe one drug can treat both disorders. So identifying patients who may be candidates for biological therapy for chronic rhinosinusitis with nasal polyps, the updated EPOS euphoria criteria. So what are the indications? Is there an indication for biological treatment? There's a presence of bilateral, as we talked about earlier, it might be a suggestion, in patients who've had endoscopic surgery. And then 3 criteria are required. They have either evidence of type 2 inflammation, and here's where you get a complete blood cell count with a blood eosinophils, a total IgE, and if amber, on sampling tissue eosinophils, more than 10 per high power field. A second criteria is the need for systemic corticosteroids, or if there's a contraindication to systemic corticosteroids. If there's a significant impaired quality of life, there comes our SNOT-22, if it's greater than 40. If there's a significant loss of sense of smell, whether anosmic on smell test, if they could do that, and if they have the diagnosis of comorbid asthma, and if they really need regular use of inhaled corticosteroids. So next question. When assessing whether a patient with chronic rhinosinusitis may benefit from biological therapy, which factor will you now most often evaluate first? Number 1, presence of comorbidities such as asthma, eczema, or aspirin exacerbated respiratory disease. The patient's prior sinus surgery history, severity of nasal congestion, reduction in or loss of sense of smell, the patient preference for avoiding surgery, or 5, I'm not sure. So let's take a few moments here. Good. Yeah.
So can I add a couple
You
of
betcha.
things, Chris? So a couple of things that were talked about, the presence of bilateral polyps, and then confirming the presence of CRS with nasal polyps. I think it's really important. I know that a lot of patients get put on biologics because of the presumed polyps, but it really is important that you have the diagnosis that it is a nasal polyp. Sometimes there are malignancies that can present that look like a polyp. So if they're not responding to treatment, maybe they didn't have a prior sinus surgery, and so they've never seen an ENT, I would highly recommend having, unless you feel very comfortable doing a rigid endoscopy and looking and getting that diagnosis. But I think that that's really key, because I have unfortunately seen some patients put on a biologic that actually had an underlying inverted papilloma, which is a type of tumor, and they can look a lot like polyps. So, if they're not responding as you expect, get that diagnosis. And also, just another thing, for those of you who treat patients in the South, we do have a subtype called allergic fungal rhinosinusitis. They are one of those unique subtypes of CRS with nasal polyps, but they can sometimes present with unilateral disease. And they just got a new indication for biologics, which I'll talk a little bit about. So they sometimes can present with, a unilateral presentation. But again, I think that's where that whole multidisciplinary management of these patients is really critical.
And even like localized disease. Like we can say I can skin test and do a blood test for IgE, but there's local allergic responses that you would be able to obtain surgically that I could not. Yeah. So yeah. Oh, so comparing available biologics for chronic rhinosinusitis treatment with key clinical trial findings. So this top row we have here the medications, the biological agents for the nasal polyp score. So in the Liberty study here, we're looking at dupilumab, how much reduction in the nasal polyp score versus placebo. Omalizumab showed a decrease with their polyp 1 and polyp 2 studies. Mepolizumab also showed a decrease, and tepalizumab, a tongue twister, in the Waypoint study. Very similar patterns we're seeing in the nasal congestion score for each medication. So here is the dupilumab studies. Again, omalizumab in its 2 studies, mepolizumab, and tezepelumab. And this is the follow-up that Amber was alluding to earlier, the sleep quality disturbance with CRS after treatment with dupilumab. So a total of those 29 patients that were enrolled, and their baseline sleep quality steps were as follows. An ESS score, excessive daytime sleepiness, had decreased from a baseline at 24.1 down to 6.9 after 3 months of treatment. Their insomnia score went from 79.3 down to 37.9. And with those with altered sleep quality, went from 93% down to 55%. And then the SNOT-22 score decreased. So what was the phase 4 Everest study? This was comparing dupilumab to omalizumab in patients with comorbid CRS with nasal polyps and asthma, okay? And this is the first head-to-head comparing the biologics efficacy and safety in this group. So what you see here is how much dupilumab reduced the nasal polyp score compared to omalizumab, improved the UP smell, University of Pennsylvania sleep smell, SIT score, improved with omalizumab. The loss of sense of smell improved much better with dupilumab, and then the SNOT-22 score improved as well with dupilumab. And then also comparing overall, not just those 2 medications by themselves, but all the other biologics. So data from phase 3 randomized trials were synthesized using forest plots in an indirect comparison of the different biologics in terms of relative efficacy. And what you see here is, of course, like here's dupilumab moving much more greater from the 0 or the 1 compared to omalizumab, in term to benralizumab, mepolizumab, and omalizumab, and tezepelumab also moved significantly. Now changes in nasal congestion score. Also, you see very similar analogous changes, how dupilumab had much more greater of effect compared to benralizumab, mepolizumab, omalizumab. And then the loss of sense of smell and these 2 scores. You're seeing a pattern here where the anti-IL-4 receptor alpha is leading to greater changes and improvement in smell. So as you saw, the dupilumab and tezepelumab were kind of moving to, but how do you compare those? Now, this is more recent, so results from a recent study showing matching just an indirect comparison of the phase 3 sinus and waypoint studies. Dupilumab significantly showed greater improvement in nasal polyp score at 52 weeks for dupilumab versus tezepelumab. And there's a significantly greater improvement in loss of sense of smell at 24 weeks in patients with dupilumab and tezepelumab. And then also, dupilumab led to a rapid improvement in nasal congestion and loss of sense of smell. This is from the Aroma Registry, a post hoc analysis of 681 patients from a phase 4 registry to evaluate the real-world effectiveness, not just in a clinical trial, of dupilumab. And after 28 days of treatment, in terms of nasal congestion, there was a 31% improvement in severity of nasal congestion, and that was even seen by day 7, but day 4, and continued at 14 and 21. And there's also improvement in loss of sense of smell, so about a 31% again improvement in severity of loss of sense of smell, but can be seen as soon as day 7, 14, and 21.
So as I've mentioned, so Chris presented a lot of some of the summary of some of the data that's been done in CRS with nasal polyps and how those studies showed was able to get FDA approval for the management of CRS with nasal polyps. But in all of those studies, a specific subgroup, as I've mentioned earlier, allergic fungal rhinosinusitis, were excluded from all of those trials because they are very unique. They present a little bit younger. They show very characteristic imaging. So for those of you who are familiar, you can sometimes see bone erosion, you can get expansion of these sinuses, very dramatic changes. You can have unilateral presentation. So because of this unique aspect of this cohort, they were excluded from all those trials. Until recently, there was a randomized controlled trial called the Liberty AIM study, where they looked at dupilumab and placebo in specifically allergic fungal rhinosinusitis patients, and it went down to the age of 6. And as similar to the Sinus 24 and 52 study, their results were very similar. So they had very good improvement in the CT score, so their CT changes were significantly improved. You can see here the nasal congestion score, nasal polyp score. Those are the different endpoints that Chris had talked about were all very good, even in fact, even better. The nasal polyp score was actually even better than the original Sinus 52 study. So it looks very promising even in that subgroup of CRS with nasal polyp patients.
So then, what are the emerging therapies? So, now we're into depemokimumab. Now this is an ultra long-acting anti-IL-5 agent. So as opposed to receiving it every 4 weeks, you'll receive it just twice a year, every 6 months. So the phase 3 Anchor 1 and Anchor 2 studies show statistically significant improvements in the co-primary endpoints of total nasal polyp score and mean nasal obstruction response score versus placebo in patients with nasal polyp, CRS with nasal polyps. And it was well tolerated, no major side effects. And then very similarly, a new medication coming down the pipeline, stepokibart. I haven't seen this one as a be approved, but it's an anti-IL-4 and anti-IL-13 receptor alpha, but has a different epitope than dupilumab. The findings from its studies, the Crohn's 2 phase 3 study, showed that among patients with severe CRS with nasal polyps treated with intranasal steroids, the stepokibart reduced polyp size and severity of nasal symptoms at 24 weeks. And with serious adverse events were rare, with higher rates of arthralgias and hyperuricemia reported versus placebo.
So it's important to remind you guys that these are not yet FDA approved for CRS with nasal polyps, but Depi was recently approved for asthma. But the company chose not to proceed with looking at for CRS with nasal polyps quite yet because the improvement was not as significant as other studies, and so I'm not sure where the company's going to go with that at this point.
Okay, and so this is our QRS code for your reminder.
Yeah, just a reminder to be participating. The more you jump in and answer questions, the more likely you're going to have to win the gift cards and goodies. Okay, so we're going to return to our patient, Jack, where we left him. He had just walked into the clinic. He's complaining of recurrent nasal polyps. In our clinic, we did a CT scan. We confirmed, based on nasal endoscopy, that he does have polyp regrowth. We actually chose to treat him medically first. He got a burst of steroids. We initiated him on mometasone and saline irrigations twice a day, brought him back in a few months, and he was continuing to have problems. So he did undergo a revision sinus surgery with our group, including a draft 3. So for those of you who may not know, a draft 3 is a procedure that basically connects your right frontal and your left frontal. So that intersinus septum and any intersinus septal cells are removed in the course of endoscopic sinus surgery, and it basically creates one big cavity in the frontal. Purpose of that is to really maximize topical steroid irrigation delivery to that frontal sinus as well as the rest of the sinuses. So he had what we would consider the most complete version of sinus surgery. He's managed postoperatively on topical steroid rinses. He continued to complain of hyposmia. We added on that exhalation device, fluticasone nasal spray. And about a year after his surgery, he still was not feeling the best that he could, and we were starting to see signs of polyp regrowth. Despite maximal surgery and despite maximal topical steroid irrigation and spray. The other kind of like more concerning piece in thinking about the patient as the whole, when he initially came to us, his asthma was pretty well controlled. He used his rescue inhaler from time to time. He hadn't had any hospitalizations, anything like that. But now over the course of this past year, he had had a significant worsening. He'd been initiated on daily inhaled corticosteroids and actually had a hospitalization related to his asthma. And so sitting with this patient now, what are our next steps?
So I'll say, I guess for me, the first step would be just to really talk to the patient and find out how compliant is he on his medications. Because I find that a lot of times, and as we're getting busier and busier, we don't have a chance to talk to the patients and really explain to them that this is a chronic inflammatory disease process. So a lot of patients think it's a surgery, one and done, and I'm good. And then they're surprised when the polyps come back. So that's the number one step. It's just to really make sure that they're being educated properly. And understand that. And I try to use the analogy of arthritis. I think a lot of patients understand arthritis, and so they say, I can say this inflammation of the lining of the sinuses, you really do need to have the anti-inflammatories. And if you don't, then this is what happens. And then I think the other thing is just to highlight from his history, a draft 3 sometimes is our go-to surgical approach because it gets into the frontals, and where the polyps recur in the frontals, it's right by the olfactory cleft, and kind of that's our best chance at helping to address loss of sense of smell from a surgical perspective. And so the fact that he's still having this loss of sense of smell, which I don't know about you guys, but if you've ever lost your sense of smell, it doesn't sound like it's really that debilitating, but you don't enjoy your food as much. And they really talk about how this can be a really, detrimental to their quality of life. So the fact that he hasn't gotten his sense of smell back despite this surgery is, some of the things I think about and worry about.
Yeah. Thank you for mentioning that. I think it's a really critical piece as a PA when you are oftentimes spending a little bit more time in the office with the patient to be doing that education piece and ensuring compliance. You're the one answering the phone when they're calling the clinic with exacerbation symptoms, and you can be working through your own ladder of, are you doing your rinses twice a day? And I just think that's really such a key piece for us in particular.
I think in that asthma realm, that paradigm exists very strongly. I mean, they have to be adherent to their medications before you step up. That's part of the guidelines. But I think also, this is a gentleman, probably you're at risk for polypharmacy. So if you start putting a lot of medications, you're only going to compound the problem. So you want to really make sure they're actually taking what they are before you exacerbate the problem. So, yeah.
Yeah. So what would be some of the treatment options for him at this point?
Yeah, so unfortunately, as you mentioned, he's sort of gone through all of the surgical options. If it was done at Penn, and I know those colleagues there, they do a very good sinus surgery. But if it was done separately, I would make sure that a CT scan is done if you're worried about recurrence of polyps, just to make sure that, in fact, they did have a complete surgery. Because oftentimes, if the ethmoid sinuses are not addressed completely, so the ethmoid sinuses have all these little partitions, little cells, little rooms, and if they're not opened up appropriately, then you're asking for a recurrence. So making sure that the surgery is complete. And then after that, then he is kind of limited, right? We don't want to do oral steroids on a routine basis. His asthma is acting up. And so I think that he would be a good person to really initiate that conversation about biologic therapy.
Yeah, agreed. Yeah.
Absolutely. You guys have hit all the things. So we'll move on here. This is a great decision tree ladder here for escalation of treatment for your patients with chronic sinusitis. So the majority of your patients who are struggling, you're going to be able to offer them some kind of sinus surgery, followed by routine postoperative management, and they oftentimes will do well. And then if we're kind of following down here, symptoms are recurrent past surgery. That's sort of where our patient Jack is. This is where it's time to recruit the team around this patient and start to think about other modalities that are going to help improve this patient's quality of life. We're starting to think about biologics. Like Dr. Luong said, we can consider a re-CT and seeing if sinus surgery is indeed complete, or if there's any areas of scarring or blockage that can continue to be addressed, if that's what's in alignment with the patient's goals. We can re-screen. We always ask patients when they first come in the office if they've ever had a history of any aspirin or NSAID intolerance, but we can re-screen and revisit that conversation. Sometimes, especially in our AERD population, that aspirin allergy develops later beyond their polyps, beyond their adult onset asthma. So we want to be checking and seeing if this is a patient that we're worried about progression to AERD. And then we're also considering treating them with recurrent bursts of oral steroids to kind of round out your medical therapy as needed for acute worsening of symptoms. And then in this other side of the ladder, these are your patients who have a contraindication to surgery. Maybe they're not healthy enough to proceed with general anesthesia. Their asthma is really poorly uncontrolled, and that potentially is a reason why they're not great for general anesthesia. Or there are some patients that just no way, no how, I am not having surgery, or I'm not having surgery again. And those are patients where you can start to consider working them up with thoughts of a biologic.
Carly, there happened to be a question in the chat that addressed that, so I just wanted to highlight that there are some patients who they asked about whether or not someone has to have had surgery prior to initiating a biologic. And I would say not necessarily. You pointed out a couple of reasons why they are not a good candidate for surgery, or for whatever reason they do not feel comfortable proceeding with surgery, then a biologic can be an option for them. So just kind of wanted to address that question out there. But I would say that based on our data, there is still just a small cohort. We're not talking about everybody with CRS with nasal polyps should be on a biologic. And the data shows that with that meta-analysis that, a good 20%, a good 80% would respond to surgery and topical therapy. But there is 1/5 of people that we need to discuss that need it. So it's a great treatment option, especially for those who have really severe disease, but doesn't necessarily need to be after sinus surgery.
Completely agree. Yeah. Okay, question on your devices. Jane is 55 years old. She has chronic sinusitis with nasal polyps, and she's coming to you with persistent nasal obstruction, loss of sense of smell, and sinus pressure despite regular use of intranasal corticosteroids. She has a history of asthma and has expressed a wish not to have surgery. How comfortable are you now with escalating treatment to a biologic therapy? 1 would be very comfortable. Jane is an ideal candidate due to her persistent symptoms. 2, somewhat comfortable. I will consider biologics, but only if Jane has failed multiple conventional treatments, including at least 1 surgery. 3, not comfortable. I prefer to utilize conventional therapies, including surgery, before considering biologics. Or 4, I'm not sure. I haven't decided yet when biologics are appropriate for my patients. So we'll give you a few minutes to think about that. Yeah, I think we're seeing people kind of choosing those top 2 options, very comfortable, somewhat comfortable. And I think I think that's appropriate in her. If she's someone that's not interested in surgery, it is okay to counsel that that Dupixent or any of these other biologics might be an appropriate option.
But I do want to highlight that, going back to one of the points we brought up, a multidisciplinary care, right? So as a physician assistant, if you don't do the surgery, it may be difficult for you to counsel exactly what sinus surgery and what to expect. And so I would highly recommend that you at least have the patient discuss with an otolaryngologist about the surgical option, just to make sure that, in fact, this is not something that they want to proceed with. And I think it warrants at least having one discussion with an otolaryngologist.
Yeah, with the surgeon, of course.
Go ahead.
I think it's.
Yeah.
This slide is, I kind of alluded earlier to the team and the multidisciplinary team that you're going to recruit around this patient. That, just as Dr. Luong was saying, this is a multidisciplinary disease. It affects patients not just in sinonasal manifestations, but also elsewhere in the body. So you're recruiting your patient's primary care provider to be on your team here, the allergist, the immunologist, pulmonologist to get a really good understanding of their status with regard to their asthma. And then you as an APP are also really critical to this picture, taking care of the patient. This is a really busy slide, but all of the different things that we are doing every day in our clinics, I'll speak for myself. I meet most of the new patients that walk into the clinic. I'm the first person that is greeting them. I am sitting with them, taking their complete medical history. I'm really looking and listening for those signs of type 2 inflammation. I'm scoping them. I'm making the decision whether or not we're gonna get a CT scan in our office. I'm looking at that with the patient and starting to do a lot of the education piece up front before they even meet the surgeon. So you're a really critical part of the team and bringing them in. We're also following up with these patients, doing their postoperative care. You're answering questions when they call, having complications. You're following up with them in the office when they're 3, 4, 5 months out from sinus surgery and scoping them, looking for adequate response to the therapies that have been started. And then patients that are still continuing to struggle, you're the one who is oftentimes spending that time with the patient. They're telling you what their concerns are. They're telling you what symptoms are continuing to be bothersome to them. And you're in a really great position to advocate for the best care for that patient, especially as the clinics get busier and busier. And then just education, counseling. You are spending a lot of time reviewing how to do the irrigations. You're talking about technique. You're talking about frequency, and kind of guiding patients on how to get the most out of their sinus care. This is, I believe, a repeat slide, but it just shows the different biologics that we've spoken about today. And it's a reminder that as you're considering the patient as a whole, they may have some of these other indications. And so when you're thinking about which biologic they might be appropriate for, just keeping in the back of your mind, if it's that allergic fungal sinusitis, which biologic can we use to help target that? If they have eosinophilic esophagitis, which one can we be thinking about? Comorbid asthma, food allergies, urticaria, all of this kind of goes into your complete picture of the patient and how you're going to choose to manage those recalcitrant symptoms.
And I think this highlights the whole need for multidisciplinary care, right? So, in fact, before this symposium, Chris and I were talking about a common patient, and so he may think about things that are more important with asthma, and then I think about things that are more important and due to their sinuses, and then it's that discussion about, okay, well, so-and-so, here are some, better or whatever biologic therapy that may be more appropriate given certain things, right? So one of those things may be serum eosinophil levels are one of those important, differentiators sometimes that can be used to choose a biologic.
Yep.
So we'll round out Jack's case. We left off with him, polyp recurrence despite maximal topical steroid therapy, maximal surgical options. We sent him to allergy and immunology, who in our case also does some asthma management as well. Kind of got him the full workup, and we ultimately restarted him on dupilumab. He's had a much better trajectory. His asthma is much better controlled. His sense of smell is back, which he's very grateful for. And on his last endoscopy several weeks ago, you can look straight up into the draft 3 cavity, wide open frontal sinus, no polyps, and he is doing really, really well. So when we're choosing to start a patient on a biologic, what kind of information can we share with patients about what to expect starting that medication?
I think you should expect you can see sometimes very rapid, but sometimes it takes a few months to see a complete, assessment of is it working or not. So you have to kind of set expectations, almost like 3 to 6 months. Okay, especially on the dosing.
Yeah.
So
I would agree. I typically tell patients to let's give it a good 6 months. And then if there's, I know that this question here says about 12 months, but I would have already assessed them at 6 months. And if there's not a good response, I go back to the drawing board, make sure we're talking about, is the diagnosis proper? Right. We didn't really have time in the symposium to talk about that there are these endotypes, right? There are, although we're talking about CRS with nasal polyps, and primarily in the US, most patients do have a type 2 inflammatory profile, but we're starting to appreciate that there's these other types of inflammatory responses like a type 1 or a Th17, and they look a little bit different and they won't respond as well to these type 2 targeted biologics. But making sure that diagnosis is appropriate. So those are some of the things. Yeah,
100% agree. The paradigm works for the upper respiratory tract, same as for the lower respiratory tract, and kind of also the patient in total. In asthma, if you take the severe asthma research protocol, SARP studies, they had about 5 different subtypes. Only one of them was the young allergic. Then you have the eosinophilic. Then you have the paucigranular, is it neutrophilic? Mm-hmm. And who's going to respond? And you try to get, as best you can, a measure. That's what we're trying to grasp with the tools that have been validated, our serum eosinophils and our skin tests or serum IgE, specific IgE testing, and the total IgE to select the biologic, which we're hoping will work best, but experience will tell us. Time will tell.
And yes, we're going to talk about how do we assess the response for starting a biologic. So when you've started a patient on a biologic, there's about 5 areas that you want to be asking them about and thinking about. That is reducing the actual size of the nasal polyps that you can see in the nasal cavity. You're also monitoring their frequency for need for recurrent bursts of prednisone, oral steroids. You're following up on those patient-reported outcomes, the SNOT-22 score, your question of olfaction disorder scores to give you a sense of whether or not this is improving their quality of life. You're asking them about their sense of smell, and then also about the reduced impact of their type 2-driven comorbidities. If you are able to show improvement in 4 to 5 of those areas, we would call that a good to excellent response. 1 to 3, that would be a poor to moderate response. And then if there's been no response in any of those at all, we definitely want to evaluate that quickly and get the medication off or changed pretty quickly. So just like this slide says, we should be really looking at that within the first 6 months and then reevaluate after a year if there's still any concern. And we want to, like I said, we want to discontinue that medication if there's been no response whatsoever. When to expect results, we've seen some really great data that some of these changes can be fairly immediate within a week or 2. They may take months, though, as Dr. Codispoti was just sharing with us. It can take that amount of time to really downregulate some of that inflammation. And so gradual improvement is normal. We are expecting patients to tell us that they've had decrease in their nasal obstruction, decreased polyp size, their sense of smell should be popping back up, and then we're also, in our clinic, we're collecting SNOT-22 scores at every visit, and we're really able to point to that and show the patient, look, you've come down so much from the last visit. If the response is inadequate, we want to check them back in 6 months and sort of reevaluate that decision ladder. So talking about adherence to their topical steroid irrigations, topical steroid delivery systems, if that applies to them. Again, we're screening for the need for aspirin desensitization or further workup along that pathway, seeing if we can do anything better to control their asthma, considering switching biologics, or in patients that may be on endoscopy, you're seeing a lot of scarring. You're now no longer able to look into those sinus cavities, thinking about potentially rescanning and reconsidering surgery if appropriate. We just want to set realistic goals. The biologics are intended to help improve their quality of life. It doesn't necessarily replace their need for surgery in all cases, but work best as part of a long-term management plan with all of your team players. So, rethinking your choice, Jane has begun treatment with omalizumab, and after about 6 months, reports little improvement in her sense of smell. What would be your next step? One would be to continue omalizumab for another 6 months and then reassess. Number 2, discontinue the omalizumab and begin a low dose of oral corticosteroids. Number 3, switch to dupilumab. Number 4, refer her for surgery, or 5 is I'm not sure. Yeah, looks like most people are saying that they are kind of between switching to a different biologic to see if we can get a better response versus giving it a little bit more time. Some people are choosing to refer for surgery. Yeah, we've talked about all of those different options and really just patient-specific, what are their goals, and talking through all of those different options with the patient.
So we're going to conclude here, but then obviously we'll have our question and answers. But really want to take home message is that chronic rhinosinusitis is a commonly, at least in the Western world, is a type 2 driven disease with significant quality of life impact, such as on the sense of smell, their sleep. A lot of times, patients who undergo surgery will still remain challenging to control, and so that is at least a 20% group of people with CRS with nasal polyps that are not well controlled despite these treatments of surgery and topical therapies. And biologics, there are 4 of now that are FDA approved for CRS with nasal polyps: dupilumab, omalizumab, mepolizumab, and tezepelumab, that help to address the underlying inflammation. As I mentioned, it's an inflammatory disease process, so it's addressing that underlying inflammation. But we also talked about that with all these treatment options out there, that we really need to think about the patients and what their symptoms are, what are their concerns, that are to provide this sort of personalized medical options. Not everyone is going to necessarily respond to the same treatment algorithm. And then also really highlighting this multidisciplinary care. As you know, a lot of these patients have other comorbidities as well as different issues to think about. I think it's really important to involve our other colleagues to make sure that we're doing the right thing by the patient. So with that, I will go to some of these questions that we've received throughout the symposium. And one of those is, we talked about these other comorbidities. So Chris, have you ever prescribed, or do you have concerns about prescribing a biologic that is addressing an IL-4, an IL-5, or IL-13, or a TSLP in someone who's already getting a biologic for another indication, like for a TNF-alpha or IL-17? What are some thoughts that we should have when we see that in their history?
Yeah, I mean, I think always, it raises concern what could be the unintended consequences of when we're knocking out, or inhibiting one branch of the immune system. I think as time goes by, I think we're getting more and more comfortable looking at the, how things go. I have a lot of patients, with a rheumatological, like on Humira for many different reasons, and some of them also with chronic migraine medications. So I'm getting more and more comfortable, even with when there's initial, your type 2 inflammation is to fight against helminths and parasites, and that was always a concern. But, we had a nice expert who spoke to us, and he was saying, our colleagues in South America have not seen that. And so we're not as concerned. And I wouldn't say you are immunosuppressed on any of these biologics. So I think that was one thing we should put the rest, yeah.
Okay, great. Carly, we talked about, when to start thinking about a biologic and recurrence of nasal polyps after surgery. When would you say is a quick return? When should someone who is helping to take care of someone post-op be concerned that this recurrence of polyps is quick and that we need to think about something else other than topical steroids and irrigations?
Thank you for the question. I think it's important to get the patient through the immediate post-operative period and get them fully healed from whatever surgery they have just had. And I would give that like 2 to 3 months. And ideally, we're hammering on them about their home regimen of the steroid irrigations. And if we start to see things make a marked improvement and then come back, probably after that 3 or 4 month mark, I would say is pretty quick. What are your thoughts?
Yeah, I would agree that usually if I give it 3 months for the surgery, and then if they're still not the polyps coming down, the inflammation coming down, the mucosa not looking like it's normalized, that's when I start maybe even initiating the paperwork at that point. And sometimes, Chris, you brought up the nonsteroidal, exacerbated respiratory disease. In those patients, if they already come in with that diagnosis, prior to surgery, I might already start the biologic paperwork because I know that they'll respond really well to surgery, especially if they haven't had it. But I want to get a good clean out so that way they can apply the topical therapies. These are really challenging patients, so sometimes they do require topical steroids and their biologics. So I'll start the paperwork then, see how they do with the surgery, and if they do great, then we hold off. But if they don't, then they've already got that going because we do know that sometimes that paperwork can take a little bit of time to go through the insurance situation. One last question. Do you believe, and I'll ask this of Chris, do you believe that a type 2 inflammation can trigger a type 1 inflammation in the sinuses?
I'm not certain of that because you understand that when you have type 2 inflammation, you're actually turning off type 1. You're inhibiting, you're skewing the immune response. So as someone skews that way, you're more less having that type 1 response. So I can't say that you would have too much of a type 1. I mean, as inflammation goes on, this gets to like someone who has, in the asthma realm, there's allergic, but then there's a ceiling treatment threshold. But that's kind of not as common as you would expect. So no, I wouldn't say type 2 triggers type 1.
Yeah, but there definitely, that question is very insightful, I think. But one of the things to highlight is that not every CRS with nasal polyp patient is a type 2 inflammatory profile. And especially, at least I've seen, because I scope all of my patients generally with polyps, there are these older patients that present with polyps, and then you can see pus mixed in with it, and they've got this mixed endotype. So there's definitely a type of CRS with nasal polyps that you'll encounter where they don't respond to your typical medical options, they don't respond that great to surgery, and then they don't respond to the type 2 biologics. That's where we have to be a little bit creative. There are some clinical trials addressing, CRS without nasal polyps or a type 1 inflammatory process, and people in Asia, because they see a lot more of this type of profile, they have tried long-term macrolides. We don't really have time to talk about those, but there are definitely different options. So it's going back to what Carly brought up, is that if your patients are not responding as you expected, you kind of have to go back to the drawing board after especially if you're finding out that the patients are compliant, making sure we didn't miss a malignancy, making sure that this is not some sort of autoimmune disease, making sure that they don't have an immunodeficiency, or making sure that maybe it's a mixed endotype that needs to be addressed more globally.
Yep.
Okay, any other questions? I don't see anything else on my iPad here, and I know we're coming to the 1:30 mark. Any questions out in the audience? Okay. Well, I hope you enjoyed your lunch. Thank you so much for your time and attention, and enjoy the rest of the meeting.
Thank you.